Good morning, everyone. Welcome to our breakout session. This is session number 4, and it's on the effects of ACEs and social determinants of health and its connection to the Pathways Hub response. We're going to welcome 2 experts in their field. We are very lucky to have them here. Just a little bit about them and their presentations today. Utilizing research done during the 6 years of research earning a doctorate in education, Tanikka Price will describe ACEs' effect on social determinants of health, utilizing the data collected in her dissertation. The impact of ACEs is particularly harmful to African-American women and significantly contributes to the continuous health inequity found in all levels of healthcare, from infant and maternal mortality to asthma, diabetes, cancer, and autoimmune disease diagnosis and subsequent mortality. Jenelle Hoseus will describe how the Central Ohio Pathways Hub is set up to respond to the very social determinants of health, which are a result of ACEs in communities. Using a health equity lens, Jenelle will highlight the community health worker process and the closed loop process that enables clients to move out of the shadow of ACEs into the light of health and wellness. Just a little bit of background about our speakers. Dr. Tanikka Price uses her training as a lawyer, her passion as a motivational speaker, and the knowledge she gained during her doctoral training at North Central University to develop curricula to educate and train others in caring for and taking responsibility for their own health and healing. She is currently the Director of Education at the Healthcare Collaborative of Greater Columbus. She earned a doctorate in education this spring, researching the effects for adverse child experiences on African-American women's educational attainment at North Central University. She also has an American Culture degree from Vassar College and a law degree from Capital University Law School. She is a member of Mount Zion Missionary Baptist Church and the Columbus Bar Association. Jenelle Hoseus has spent the last decade dedicated to public policy and healthcare advocacy. In her current role at the Healthcare Collaborative, Jenelle has taken on the role of Executive Director of the Central Ohio Pathways Hub. The Healthcare Collaborative of Greater Columbus is an independent, not-for-profit organization committed to transforming the quality, delivery, and affordability of healthcare to ensure that all people in the Columbus region have the best healthcare experience possible. Through the hub model, HCGC ensures that all at-risk individuals in Central Ohio are able to access care and services to better support a positive health outcome and quality of life. Jenelle and her husband, Steve, live in Dublin with their 2 sons and 2 dogs. She is actively engaged in the community and enjoys playing with her family, traveling, running, and reading on her porch swing. Without further ado, Tanikka and Jenelle, welcome. We appreciate your being here and we're looking forward to your presentations.
Thank you. Thank you. Well, good morning, everybody. It's our pleasure to be here. The goals of our presentation, we are going to describe ACEs and how they contribute to social determinants of health. We're going to describe social determinants of health. And then we're going to describe how the Central Ohio Pathways Hub model responds to those social determinants of health, thereby addressing the lasting effects of ACEs. And you heard all about us, but this is how our presentation is broken up. So we already went over this in a previous seminar, but the ACE questionnaire does measure traumatizing experiences of an individual younger than 18 years of age. And research has indicated that individuals who have an ACE score of 4 or more have adverse mental and physical health consequences. And again, that's from Drs. Folletti and Larkin. The term and concept of ACEs are far-reaching, and they encompass other measures such as physical and emotional abuse, childhood sexual abuse, and neglect. What's really important is trauma is an overwhelming experience that evokes the feeling of helplessness and fear. So a lot of times you may have 2 siblings who go through the same experience, and one of them finds themselves traumatized and the other one doesn't. And it could be because that one sibling was able to find agency. So an example of this is a fire. You know, if the house catches on fire, one sibling may just sit there and be in panic. Oh my God, the house is in fire. While the other sibling may be running around, getting younger siblings, gathering belongings, trying to get out, you know, accessing the window. So that sibling that finds themselves with more agency may have less traumatic enduring residual effects from the event. The experience and effect of trauma in students in school are widespread. So as you see, over 25% of all students will experience an event that will affect their social, emotional health and risk their academic achievement. Researchers link trauma to various problems in adulthood, including poor health outcomes, mental health problems, homelessness, and crime. People with high ACE scores are less likely to graduate from high school or from college. So my particular research, I really wanted to look at whether or not individuals who had ACE scores of 4 or more were less likely to graduate from high school or college. And I wanted to see what the effects of those ACE scores were on those individuals. I used questionnaires, an interview survey, and in-depth interviews. And educational attainment was measured by the completion of an educational program, either at the high school or the college level. And then the ACEs were measured by the ACE questionnaire. I really went into this research expecting to see that people who had high ACE scores, who were able to graduate, would come out better than those who had high ACE scores, but who were unable to graduate. Social determinants of health. So the definition is the conditions in which people are born, grow, live, work, and age. Social determinants of health are shaped by the distribution of money, power, and resources throughout local communities, nations, and the world. Differences in these conditions can lead to health inequities or the unfair and avoidable differences in health that's seen within and between countries. And this is a physical example of a social determinant of health. So as you see, the people at the bottom, and then education, access, and quality, which is what I researched, healthcare and quality, the neighborhood and the built environment, social and community context. And, what was that on my end? So, and economic stability. This is a pretty new example of a social determinant of health, and it really breaks down how all of the things on the left really contribute to the things in the middle, the Maslow's hierarchy. And so if you see unemployment, lack of high school degree, again, what I studied, ex-offender reentry issues, people feeling overwhelmed, new parents, lack of parenting role models, domestic violence, mental health issues, inadequate education services, food insecurity, benefit issues, utility shutoffs, and poor housing. All of these things build on each other, and they affect the individual's ability to achieve potential, which of course is the highest level of the Maslow's hierarchy. And then on the right, you see the community-based interventions, which are a lot of what we do at the hub. So we connect people to services that get them to these things that are on the right that will help their lives.
So thanks, T. So in order to understand why we do what we do, in particular at the hub, we have to acknowledge how we got here. And so we really feel like it's necessary as we do presentations like this to take time and hold space to acknowledge the hundreds of years of racism that have impacted all of the public policies that directly impact people's lives and their quality of life, health outcomes, all of the other components of work that we are trying to impact at the hub. So here, not that many of us need to be reminded of it, but again, holding space to be reminded of it. This is the timeline of white supremacy within the United States, and really just kind of taking a moment to acknowledge this is, 400 years worth of time. And we are just now getting to a point where we're trying to, at least we are, trying to acknowledge that we need to be doing more proactive work to engage folks, to try to bring people to a space where they have access to what they need to be living positive, healthy, fruitful lives. And so we just need to acknowledge that this is what brought us to this point in time. So at the hubs, there's a network of us across all of Ohio, and we call ourselves the network. And at the network, our slogan has slowly become, we are the other 80%. Because when you look at this pie chart, you can see that 20% of a person's health outcome or quality of life is determined by what happens within a clinical setting. But health behaviors, social and economic factors, and physical environment contribute to that other 80%. So we consider ourselves at the hub the other 80% because we are what is impacting everything outside of that clinical space. So we like to use this slide, it's data from AmericanProgress.org, to really kind of remind folks some of the disparities that we see in public health right now. So in 2017, we were looking at healthcare coverage, and 89% of Hispanics said that they had healthcare coverage access, whereas 93.7% of white non-Hispanics had access. For asthma diagnosis, we had 12.6% of Black or African American children had an asthma diagnosis, whereas 7.7% of non-Hispanic white children did. And then related to having a fair or poor health condition, 17.4% of Native American or Alaska Natives said that they did, versus 8.3% of non-Hispanic whites. We know that there are disparities across the healthcare spectrum, right? In Franklin County, we hear it frequently related to our infant mortality numbers. But we try to bring this up not only to showcase the disparities that exist, but to also talk about the fact that while data and statistics are obviously phenomenally helpful in creating a narrative and understanding the issues, there are human lives behind each of these numbers, right? There's a human impact. And so we need to take the time to say, yes, there are definite disparities here, but who is it impacting? What are the lives that are being impacted, and how do we change it? And so that's part of what we're trying to do. So the Pathways Hub model has been in existence for over 20 years now. Dr. Sarah and the late Dr. Mark Redding started working on this over 20 years ago after they had lived in Alaska for a while. And they are out of the Mansfield area. And now Sarah is the founder of the Pathways Community Hub Institute. The basic premise of the model is under the guise of 3 steps. So it's find, plan, and treat. So we at the hub, we call ourselves the middleman. And normally I have a fairly negative connotation with that phrase, but for the sake of argument here, let's go ahead and assume it's a positive one in this case. In the middle, we have us as the hub. On one side of the spectrum, we have the Medicaid managed care plans or other payers. And we have direct contracts with them. And those contracts specify payment points for the work that we accomplish, HIPAA expectations and obligations, referral patterns for any members that they have that might benefit from services. We also become their single point of contact. On the other side of the spectrum, we have relationships with what we call care coordination agencies or CCAs, Franklin County Public Health being one of them. They are the entities that employ community health workers. So they are working with us to make sure that their CHWs and their hub staff teams are fully educated about the model and overseeing all of that work. The CHWs are meeting with at-risk individuals in the community. It could be through referrals from us, from the managed care plans or other community partnerships. It could be walk-ins at their clinics. It could be canvassing events. But regardless of how they meet that individual, they build a trusting relationship with them. It's expected that the CHWs are meeting with them either in person or remotely for an extended period of time, at least once a month, to continue to build that relationship, do check-ins. But the first time that they sit down with that individual, they do what we call a checklist, which is really a comprehensive risk assessment. That risk assessment is talking about everything that has brought that person to the moment that they're in. Chronic conditions, previous pregnancies, mental health screening questions, are they housing secure, food secure? All of the things that give us a better understanding as to what all they might need right now. And then maybe there are some layers to the onion that we need to work on pulling back. So based off of the checklist, as well as a conversation with the client, because we obviously want our clients to participate, the CHW will then determine goals, and we call those goals pathways. There are 20 distinct pathways. And for example, if the CHW through that conversation realized that the person doesn't have a primary care clinician, they would open up what we call a medical home pathway. So that requires that the CHW finds an appropriate clinician's office. They have to be culturally competent, linguistically appropriate,
accept their insurance, all of the things to reduce the risk of that person not having a positive experience with that clinician's office. Help the person set up their first appointment. But then the pathway isn't considered closed and completed successfully until the person has confirmed that they did attend the appointment, right? So it's a closed loop referral. So the client profile, any checklists, all of the pathways that are done, all of that is tracked and stored in a single IT platform. And then at the end of each month, supervisors are reviewing the information for appropriateness, completion, accuracy, and timeliness. We at the hub are reviewing it, and then we're auditing it and sending it off to the managed care plans, who are then reimbursing us for that work. So part of the importance of this model is understanding that it is pay for performance. So as I mentioned with the example of the medical home pathway, we don't get paid unless the work is completed. So for in that example, if the individual had got their first appointment set up, they found the right clinician's office, but then for whatever reason, the individual was not able to attend, that pathway is actually considered closed, incomplete. We don't get paid for that work, right? Because it's the idea that we are truly setting them up, we are connecting them to care, and it's confirmed that it's actually, that connection is occurring. So the pay for performance concept is helpful not only for purposes of the managed care plans, knowing exactly what folks are getting connected to in terms of support, but it's also great because we make sure that, you know, if we need to try and try again, that's what we're going to do with our clients. And so whether it's managed care plans or other funders, we're able to show them exactly what all has been accomplished. And for the record, we do have a lot of Medicaid enrollees on our caseload, but we don't exclusively see Medicaid. We see anybody that comes through the hub doors, and we serve the community at large. The Pathways Hub model originally came about in Ohio, or at least gained more popularity because of the infant mortality crisis. And so a lot of hubs do have a particular focus on maternal and child health, but in Franklin County and Central Ohio, we've really made it a very strong effort for us to make sure that we're serving the community as a whole. So this slide is a little bit dated, but just to give you all a feel for some of the work that we do, as of the end of last year, we were able to have 86% of the babies born to mothers enrolled in the hub, born at a healthy birth weight. We do serve all client types, as I mentioned, so pregnant, pediatric, and any adults. And pediatric was actually new as of the 1st of 2020. So that was exciting for us. So as I mentioned before, there are 20 pathways. These are the different pathways. And while it may not sound like a lot, this is actually very much a plug and play model. So when you look at something like medical referral, that could be anything from dentistry to lab or x-ray. Social service referral could be a mom getting a breast pump. It could also be someone getting translation services. So the notion is that regardless of the person's background, regardless of the person's need, we're able to serve them based off of the pathways available here. So this slide is also a bit dated, but we use it purposefully. And the reason that we use it are the last two columns. So you can see that we did an evaluation of our number of CHWs and CCAs, as well as clients and pathways initiated. And the last two columns, you see March 1st. So pretty much right around when COVID was really starting to come to light. And then at the end of November in 2020. And while, again, this is dated, the thing that I like to point out here is that our CHW numbers actually went down by 3 during that point in time. And we had an exponential growth in clients that we were serving. So first of all, I like to point this out because it's absolutely critical for us to acknowledge that the hub doesn't exist, it doesn't work, it doesn't function if we don't have community health workers that are out there literally going in when the entire healthcare system was so just drowning in COVID that there was very few places for our clients to go for services. And quite frankly, because of some of the social distancing and other concerns, there was a fear factor in them going to specific places, and quite frankly, an availability factor as well. And they were going in when there was a lot of need that was present in the community. And so without them, we are nothing, literally. And so we want to say that out loud. But also it just showcases that during a time of crisis, when our number of clients went up exponentially, our CHWs were stepping up to the cause. And over a 7-8 month period, saw an exponential growth in the amount of folks that they were serving and did it very, very gracefully. So just worth noting that during a pandemic that they were able to step in and really play a big role. So the hub has been really growing a lot. We have on average around 600 active clients per month. We've had almost 3,000 total clients at this point. And we've had over 13,000 total pathways that have been completed since we opened on March 1st of 2019. We've been doing a ton of effort related to COVID, in particular education, and then connecting folks for vaccine purposes. So that's been another really strong area of focus for us. These are our current 12 CCAs. We were really fortunate and just had Destin Pathways and Ross County Health District come on recently as two of our newest. But each one of these groups are absolutely phenomenal, and their entire teams are just folks that we're really, really blessed to have as part of our everyday lives and doing this work. So very grateful to everyone that's working in this. I had mentioned that there are hubs across Ohio. So each hub has a designated service region. Ours is Franklin County, all contiguous, plus Ross County. And so when you think about that, it's the notion that we really want to encourage that if there's going to be care coordination and reaching out to folks, that we don't want multiple care coordinators care coordinating, right? Because then we need a care coordinator for the care coordinators, and it's just too much. So these are the designated areas for the hubs across Ohio. And so we are working diligently with them. Literally, we meet every week to try and compare notes and do best practices on how to reach out to the community in a really thoughtful way. And then we like to share this slide too. I had mentioned that a lot of the work that had been done in the hub space had been specific to maternal and child health. Buckeye, Centene Corporation, had done a study with the Northwest Ohio Pathways Hub several years back for the efforts in infant mortality. And they found that for every dollar that they spent on hub related efforts, that they saw a 236% return on investment. And so again, that's amazing, and the ROI is phenomenal, but those are babies' lives that were saved, and those were moms that didn't have to experience that type of trauma and pain. And so thinking about it in terms of a prevention space, and how do we support folks to make sure that trauma doesn't exist to begin with, but continue on in their lives. That's part of our goal at the hub. So it puts a numeric target, I guess, on some of that work. And then, so some of the special projects that we've been working on, we are a recipient for the Commission on Minority Health grant for infant mortality specifically. And in our first year, 92% of the babies that were born to Black and African American mothers in that grant cohort were born at a healthy birth weight, which is awesome. We're also doing ongoing work with the City Prosecutor's Office, Zach Klein, and 95% of the participants in this program have successfully completed it. So the basic premise started out 2 years ago as individuals who have committed their 2nd through 10th offense of petty theft at a big box store, that they would be offered the opportunity to participate in 6 months working with the CHW. And if they participated and worked on goals that were agreed upon between the prosecutor's office and the CHW, that after that 6-month period, that their record would be sealed and expunged. We've now expanded that out to other courts as well as other offenses, so drug-related offenses, solicitation, and we're really seeing this as just the beginning, which is amazing. We've had 153 people come through the program so far, and only 6 have shown back up in court, which, I mean, to us is such a massive win. So we're really excited about that opportunity and the expansion of that program as well. We've been working with Columbus Metropolitan Housing Authority, and we have been working with them diligently. It started even before the pandemic, but especially because of some of the CARES Act funding related to housing and utility assistance, we've been making ourselves readily available to their 35,000 residents. And then related to addiction, we're part of the CDC Data to Action Grant through Franklin County Public Health. Really grateful for that partnership. We've been able to work with them to make sure that folks who are going through treatment and recovery for opioid addiction have additional supports from community health workers as they navigate that space as well. So this is just another slide to kind of talk through the process that CHWs work through with their clients. You know, part of the goal is that, yes, we are connecting them to care and service, but through that trusting relationship, we're also trying to educate them along the way. How do we help them to understand how to navigate things so that they aren't in the hub for forever, right? We don't want them to be a hub client in perpetuity. So it's really the notion that we are supporting them and connecting them in the here and now, but also supporting them to, you know, understand how to connect themselves moving forward as well.
So one of the great things about the hub is that we do have a CHW certification program. And this goes back to something that Dr. Wade was saying, that it just takes one person, one trusted relationship to break the intergenerational cycle of ACEs. And so we educate our CHWs, we take them from the communities that they're going back into to serve. So they speak the language of the people that they're going to serve. They understand the struggles of the people that they're there to serve. And we empower and educate them to, first of all, just like Dr. Wade said, notice their own triggers, right? Realize their own trauma and what they've been through. And then by doing those practicing things like meditation, we teach the mindfulness meditation, how to do diet and exercise that's appropriate for where you are in life, and then how to reduce your overall stress by doing self-care, putting yourself first. Then we teach them to model those things to their clients. So we're really pouring into them during the 12-week course so that they can turn around and pour into their clients. And this was our first graduating class that graduated this spring. We are so proud of them. We're now into our second cohort, our fall class, and we see this going forever. So if you know people that would be great CHWs, please email us. We're getting our list ready for our next spring class, spring 22. And we're just so happy to equip them. They're already natural leaders. They're already natural connectors. We're just equipping them so that they can go into the community and not experience the burnout that is so common with community health workers, and be able to get a living wage and also give back to their community at the same time. Oh,
Yeah.
this was one too.
Yeah.
So our CHW certification right now, we've been offering it to all the employees of any of our care coordination agencies who work with us who are not certified. We're one of the few states that offer certification through the Board of Nursing. We are only the second program in Franklin County or Central Ohio. And it's a 12-week course that we offer 3 days a week to work around the work schedule. We don't want anyone to have to quit their job in order to come to our class to then try to turn around and make a living wage. To us, that didn't make sense. And we've been able to offer that virtually in COVID, which has been really beneficial. We have 3 brand new moms in our class right now who have little bitty infants that they sit and hold and rock during class, you know, and that may not have been possible if we weren't virtual. They may not have been able to get a babysitter to be able to come to our class in person. So we're really happy that we've been able to accommodate during COVID. In addition, we have monthly CHW meetings. So everybody that is in the hub, all the CHWs, we meet monthly. And we try to be really responsive to issues occurring in the community, including like here in Central Ohio, violence. So we had the brand new police chief. She had only been in for 8 days, and she came to talk to our CHWs about how they could make an impact to reduce the violence that we were seeing in our community. We have managed care plans come out to talk about any new initiatives that they may have that would benefit clients. We also started something really recently, which is shout outs. So we highlight the CHWs and agencies that are doing really well. It might be somebody that finally helped someone get housing after a year, or a client who's been able to become sober and then move out of sober living facility to take care of their children. Those are the things that we really like to highlight. And then I also offer regular TA sessions as needed. So if there's a CHW, we don't want them to just quit or get fired. We want them to know that we're there to scaffold them, to hold them up, to teach them the kind of things that they may need to be well at their job. And we offer those. I do the TA sessions. I'm like the cheerleader TA sessions. And then we have Grant Botley on our team who does more of the IT, because sometimes people struggle with using, you know, the platform, the data platform. And then Jenelle jumps in when we have supervisors who may need a little bit of support to manage their team. So I see we have a question in the chat.
Yes, so for someone who currently lives in Athens, they want to know if certification applies only to those in Central Ohio.
Someone who lives in Athens. We have talked about opening up our certification program as long as it is virtual. We do have an in-person part where we do CPR training in person. So we have to work around how that person would get their CPR training, but I think we've been open to it.
The only other component that we'd have to work out with that individual is we've been really fortunate because our current care coordination agencies have been doing our practicum work. So it's 130 hours of practicum time. It's in person, shadowing a CHW. And so obviously if they're in Athens, we'd have to kind of figure out who would be an appropriate fit down there. There is an organization in the Southeast Ohio that is working to become a certified hub. So we might be able to work with them to see if some of the CCAs down there would be a decent fit.
Awesome. And I have a second question. How does the hub model help clients to transition off the pathway to self-sufficiency?
It's a great question. Do you want to start? Nikki?
Sure. So one of the things that we love is that we really, we teach clients to be advocates, to advocate for themselves. So there's a CHW, she actually works here at Franklin County Public Health. And I always use what she told me in one of our TA sessions. She said, the first thing I do is I call the agency with the person on the three-way because I want to model for them what they should be saying. And then the second time I have them call with me on the phone. So I can see if they really heard what I was saying when I called the agency. And then the next time I tell them, call the agency and let me know how it goes. And that's really what we want to do, right? We don't want to do everything for the client. We want to really teach them how to advocate for themselves, how to access the resources, and then we work towards them being self-sufficient. Great question.
Yeah, the other thing I would just add to that is that we, along with teaching them to be self-sufficient through example, we're also really encouraging our CHWs to, as you're building that relationship and you're meeting with the client, add tidbits in, right? Because part of this is slowly bringing them to a place where they, whether it's they hear it for the first time or they need a little bit of like building it up before you get to the punchline of whatever it is that you're trying to work through with them. You know, we're trying to make sure that every single opportunity that we have with the client, that we're utilizing it to the best of our ability to make sure that it's a well-rounded experience for them as well, to make sure that as they leave the hub, that they have all of the tools in their toolbox that they need to be successful moving forward. Yeah.
You had said earlier about special projects. Are those special projects shared among all hubs or are those specific to your hub?
They are specific to ours. You might see some thematic concepts. Like I know the hub in the Cincinnati area is starting to take on a diversion opportunity with one of their court systems as well. But we have been really trying to showcase that this is plug and play and that this is meant for the community at large. So anytime we've been met with an opportunity, we've gone for it. Much to sometimes the exhaustion of the team or the CHWs. And we try to make sure that the CHWs and their supervisors are all engaged before we formally agree to most of the stuff. But we've been just trying to take every opportunity we can to just show the work, the efficacy of the work. Yeah. Did you have another one?
Can you, when we have a question from here,
Repeat the question.
yeah.
Repeat it? Absolutely. Yep. Sorry.
Any other questions from the group here?
And one more.
Yeah.
Would you mind talking just a little bit about how your community health workers and your care management, care coordination services dovetail or are done in lieu of other similar types of services within the community, particularly for kids serving organizations? So job family services, community behavioral health centers, even some of the managed care organizations.
Yep. Yeah, so the question was around how our services at the hub dovetail and work alongside other potential community partnerships and or managed care plans, especially when we think about kids in particular. So it's a great question. I'll take the managed care plan piece first. We've worked hand in hand with all of the plans in Central Ohio, whether it's getting referrals from them for members that from a medical perspective seem like they have a few flags that might suggest that some social determinants of health supports would be helpful, especially in the pregnant mom space. If she's had multiple preterm births or low birth weight babies, they immediately will send them our way to try to see if that being in the hub is something they'd be interested in. We report back to the plans on all of our active clients, any outcomes that we have for referrals that get sent to us, that type of thing. We also have been working to, we haven't figured this part quite out yet, but we've been working with the plans, CareSource in particular, on if there are individuals who meet certain metrics in particular areas, the pregnancy space being like the first example. If the mom meets certain criteria, should she be referred back into their care management team for a more medically focused care management plan? So we are working on some of those details as well. With other organizations, we actually keep a running list in the client profile if they do have a caseworker at JFS, or if they have a parole officer that we need to be engaged with and things in that space. But generally speaking, we think of the CHW as kind of the quarterback to make sure that all of the parts and pieces are talking to one another. So for us, it's really not, we think of ourselves as the connection to care, not the care itself, right? So they're working with those other partners to make sure that everything is coming full circle. But generally speaking, beyond that, it really doesn't, there isn't an overlap per se, because it's more of just like, you know, air traffic controlling who's doing what and who's on first. I don't know if you have anything else you wanted to add.
No, that was perfect.
Okay.
So I have a couple.
Yeah.
I know that we're at time, we're about 1 to 2 minutes past on. You have 10 minutes.
Okay.
Oh, they extended it, thank you. So
Okay.
I do, Charles.
Okay.
So, you know, we talked about the sense of agency, right? When you have an individual in a household who has siblings or cousins or other relatives that are being developed and raised in that household, and some have agency, right? And some don't. And Dr. Wade talked a little bit about that in that framework that he presented. Could you talk to us a little bit more about that? Because that really speaks to sometimes sort of gaps in equity.
Yeah.
In terms of how that individual shows up in the world, how that individual is treated within that household, right? And what gifts, the benefits, opportunities, and access that individual and those individuals just have a sense of agency have versus others.
Yeah, that's a great question. And it actually leads to my what I was going to wrap up with, which is my findings and my studies were not that the people who were educated came out better. It was that the people with self-efficacy came out better. So remember, Dr. Wade says self-efficacy is the belief that you can do what you set out to accomplish. That was actually the biggest indicator or predictor of success in my study. And it goes right into what you're saying. It's really hard to quantify. It's one of those things, you know it when you see it. Somebody who believes in themselves despite the odds or the obstacles that they face. And this was really epitomized in one of my research study participants who did not have a high school diploma, but she is CEO of her own organization. And nobody that works with her would ever guess that she did not have a high school diploma, because she made up in her mind when she became a teen mom that she was going to break the cycles of poverty that had engulfed her family for decades. And she has been able to do that. You know, she dropped out of school to go to work full time and has, you know, bought a house, married, I mean, all of the things. So that self-efficacy is what you're talking about. There's also motivation and grit, which are really closely related to self-efficacy. Motivation can be intrinsic, which is just an internal, you know, somebody who's like, I'm going to do this, you know, I'm going to finish. I don't care what happens. And then there's external motivation, which is if you get A's, I'm going to give you $20, right? That's external motivation. Research shows that external motivation does not last. It's only useful in hitting short-term goals. You really have to have intrinsic motivation for those long-term goals. And so this ties into care coordination because the CHWs tend to be these self-motivated individuals. They tend to be people who have, you know, gone through and had grit and motivation, and they've had to advocate either for themselves or, like you said, their younger siblings or their grandmother. And so they come into this work highly motivated. And when they connect that high motivation with their clients, even if they have a client who's depressed or a client who hasn't gotten out of bed or a client who doesn't know what they want to do in life, that energy, whatever it is that you're describing, is infectious, right? And so you have a hard time learning from someone that you don't trust. And that's why trust is the basis of the relationship between the CHW and the client. Because once that trust is built, and it's built by showing up when you say you're going to show up, calling back when you say you're going to call back, you know, giving them the resources that you promised to give, those little things are what are building the relationship. And then when you make the suggestion, let's look into housing, you know, let's look into go back to school, they're more likely to be open and receptive for that. And then they become the catalyst of change for everybody around them. So we do have certain cases where there's more than one member in the household in the hub, and the CHW may be working with them, but you'll also find that once that one person gets into the hub and then they graduate, that they're able to educate and advocate on behalf of their siblings or their, like I said, their parents or their grandparents, just by virtue of watching the steps that they've accomplished in the hub.
Another question that, and this speaks more to sort of access. So how do you access your services through the hub, number one? And number two, how do you market those services so that you are reaching into the communities that are most in need?
So the question was, how does someone access the hub services, and then how do we as a hub reach into the community? Is that a fair?
The most vulnerable, the most.
Right.
So
Mhm.
not just the community in general, but those.
The most in need in the community. Yep. Yeah, perfect. So the first one is the easier one of the two. So we have all of our CCAs obviously have access to providing any of those services. So any of the organizations on this slide would have the ability to enroll someone into the hub. We also have a referral option on our hcgc.org website. And so if you go to the Pathways Community Hub tab, there is a referral platform that would then come to one of the members on our team, and he would be able to assign you to a CHW. How do we integrate into the community? So that's a deep question. So our CCAs are fantastic from the aspect, well, on a whole variety of levels, but one of the ways that they're amazing is that they are the people that are out doing this work regardless of getting paid for it, right? Like they are the ones that are the person that you would trust and call and pick up the phone to figure out how to do X, Y, and Z. And regardless of them being, you know, a certified CHW, they're going to be doing that work. They know where to go for what. So our CCAs and our CHWs already have inroads into the community just because they are from and for and by them, right? We also have done a lot of work to make sure that we are partnering in really purposeful ways and getting our name out there to understand and have the community understand that we aren't there to force anyone to do anything. We aren't there other than to be a help and to be a support and to be there when someone's ready. Maybe right now isn't the right time for you, but when the time is right, you know where to find us now. So, you know, whether it's our CCAs going out and doing that work, if we have a referral that we get from a community partner about an individual potentially needing services, even if they don't answer the phone when we call 3 times, because we always call at least 3 times before we say, okay, maybe they're not interested, we still send a letter and follow up, and it has all of our contact information to say, when you're ready, we're here for it. So our partnerships have been really strategic in that way too, and making sure that regardless of when or what the special program is or anything else, that the general knowledge is that the hub is here when you're ready to help you with what you need help with. I don't know if you have anything else.
No, that was perfect.
Okay. Yes. Yeah, by all means. Yes.
But the advanced African community in Colombia.
Yes.
How do they access the service and how would you reach them?
So ETSS has been phenomenal in that way. The question, I'm sorry for everyone joining us remotely. The question was, with the unique and diverse African populations throughout Central Ohio, how do we reach out to them? Is that a fair representation? And how do they access? Yeah. So ETSS has been doing a ton of work both in the hub and separate from the hub, and integrating some of this knowledge into the community. So they are actually partners, not just doing the hub work, but also at Columbus Metropolitan Housing Authority, doing a lot of their case management work as well, especially for those populations. The other thing I would say is that we have been really blessed because whether it's ETSS or others, we have over half of our CHWs in the hub speak multiple languages. So we've tried to make sure that as we get clients into the hub, if they have English as a second language or don't speak English at all, that we have somebody as a CHW who's able to meet them in a linguistically thoughtful way. So we've been trying really hard to make sure that we are making everybody on our team and in our CHW team culturally competent, linguistically available, doing all of the things to create a better trajectory for somebody to participate. So, and as far as them coming into the hub, it doesn't matter where they show up. If they show up at primary one and they recognize that that individual needs some hub services, any of our CCAs, if ETSS is doing work at their Columbus Metropolitan Housing Authority units, any way that they come into the hub, if there is a need that's specific to a language barrier or a cultural barrier, we try to take account for that in who we assign them to as a CHW. Is that helpful? Okay. Yeah.
Yeah, so my question is, you know, COVID and the release of so many like inmates and people leaving the justice system. Obviously, you know, the hub is a great thing for them to connected to as people coming out need many of these services and are, you know, can be somewhat institutionalized. Is there anything specific? I don't know, there might be pathways, but is there anything specific or tailored to that population that would help that?
Yeah, that's a great question. So the question was around specifically with COVID and so many individuals who had been formerly incarcerated coming out of the prison or jail system. Is there anything specifically tailored to them? That's fair? Okay. So the pathways are meant to be universal, right? So again, regardless of person or background or need state, that they should be utilized. We've had a lot of conversations with Jackson Pike around what would it look like for us to do an integration with the folks that are coming out of there, thinking of strategically about how do we set them up with care management before they're even up the door. And one of the things that we fully acknowledge is that there are certain things like even transportation from when they're released to getting to wherever it is that they're going to be living or, you know, just going after that is issue number one sometimes. So we are very aware of the intricacies there, but I would say that regardless of the individual, that the pathways would still meet their needs. We don't necessarily need to tailor the program to them because the program by nature is tailored to them to begin with, right? We're only going to open pathways that are applicable to what they need. So if it's transportation from Jackson Pike to wherever it is that they're going, maybe housing, maybe it's employment, maybe it's, you know, a group counseling so that they're not inclined to participate in whatever they were doing before. All of those things are met through the 20 pathways.
Can I just add, Destin Pathway, our newest CCA, it was, their CEO was formerly incarcerated. So that is his passion and that is his niche. So this is the kind of situation where if we knew that was the need and that's where the person was being referred to, we would definitely refer that individual to that agency. Because we know that's somebody who could speak that language, talk to them about coming out and not going back, and put them, he has jobs for people that don't have job experience, and then they're able to build their resume to get better and better jobs. And he also has housing. So, you know, that's, like I said, we have something for almost everybody. I'm not gonna say everybody, but almost, we're working on it, but almost everybody.
Thanks for the call. Yep. We are in active conversations with them as well. Yeah. Yeah.
We are at time.
Perfect. Yeah. Well, thank you everybody for your time today. We appreciate it.
Thank you.
All right, just for everyone that's in here, we do have lunch starting now, and it ends at 1:30. 1 p.m. That's why I have to double check. So yeah, it ends at 1 p.m. And if you can make your way to room 214,
And then if you're part of the sponsorship agency, that will be adding one to Dr. Wade, it will be in room 212. So 214 for food, 212 to sit and chat with Dr. Wade.
And
Thank you.
you're more than welcome to use any of the rooms to eat your lunch. Or if you want to enjoy this nice afternoon, eat outside. Or if you don't want to stay in the belly.
I say it's cold in here, I'm not saying this.
Now you're right.
I'd be lost without that.
I know.
How are you?
Yeah.
Hey, thanks for coming.
Yes, ma'am.
Wonderful job.
Thank you.
Great job. Thank you so much.
Great to eat.
I know it's
No, you are. Yes. Thank you, everybody.
Thank you so much for your great presentation. That was great. Always learning.
I'm
a
glad
lot
to
every
know,
time
so
you
now I
share.
can enjoy everything.
What are the session reviews on that? Oh, I did.
We're trying to get, CA to do the ACE questionnaire, so I'm thinking about doing one that's like trauma informed about traumatizing people. And
Okay.
everybody's scared, you know, like, I talked to all the other parents and they're like, we don't do the ACE because we don't want to trigger people. And it's like, there's outcomes, you know what I mean? Like, they're so positive, just by doing the ACE, it's gonna help people.
I heard too.
It is,
Is it?
yes,
We don't do it.
no, we're about to do that, that's my hope, that's one of my goals for this year, okay? I'm working on it.
I will email you. Around the.
I do multitasking.
I was like, I just need to get.
That's why I didn't send you a follow-up email.
Because I
Oh,
don't
I
know.
know. Listen.
Are you still, meeting another time? Remember, we session.
That's like a great one to
Okay.
show.
And room 213.
That's why they brought you, because I know you're doing it.
But
You
yes.
can work out the detail later, we got plenty of time.
Awesome.
Oh.
Yeah.
Everybody's straight. Oh, I thought you meant your presentation.
Well, we just said.
Oh, no. I did.
And then I was responding.
No. No, so if you do respond, I still might put a week, but she actually is being, recruited by Nationwide Children.
Oh, I mean, that is.
I know, but that's what I'm saying, so that's why it's like not as urgent, because she wants to see if she's gonna get that, and get that version from them hours. But I really want her to go down to here. With her, we're talking about her, to hire her. And I'm so particular about who I'm going to see, because I mess up with my name.
We're not.
I have this one city